Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. We're at the Alan B. Levan Innovation Studio. We're very pleased to have a very significant individual, not only in the field of medicine, but in the field of research, Dr. Stephen Vanni, who is a neurosurgeon. And I believe you rank in the Department of Neurologic Surgery as their lead for HCA Florida University Hospital, but soon you'll be located right here, right within steps on our NSU campus in the new hospital, the University Hospital. Welcome, Doctor.
Well, thank you. Thank you for having me. I'm actually looking out my window. I'm looking at your campus. Today is our first day in our new office venue. The hospital's been open since November, but we're actually now officially on campus.
Good to have you. Good to have you. We want to talk about the surgery for complex spinal disorders. I'm not the physician. You are. You're the expert. So I said, let's get somebody that really can get into this area of information. So Dr. Stephen Vanni, it's all yours.
Well, thanks. So, the word complex spinal disorders is a bit of a deceiving word, because every problem with the spine is a complex problem, because the spine is a very complex and unique type of joint. The spine is not like any other joint. And what do I mean by that? Because the spine is made up of so many joints. When you talk about the knee, you have two knees. I guess you're talking about two surfaces, but when we're talking about the spine, we're talking about all the segments of the spine that make up the spine. So in the neck, there are several vertebrae. Those are the cervical vertebrae. We have 7 cervical vertebrae. So just this section makes up the cervical spine. The part of the spine where the ribs are attached are known as the thoracic spine. And the part of the spine that the lower back is called the lumbar spine, and there are 5 lumbar spines. So, and then we have the sacrum, and the sacrum is really made up of 5 sections that fuse into one as we become skeletally mature throughout our teenage years and then adult years. So you can imagine that how complex this becomes. And of course, the skull or the head articulates with the first cervical vertebra. And our legs articulate with our pelvis, which the foundation of your spine actually starts, when people talk about with the things we call like sagittal balance, starts in the feet. So the spine is very complex. And then when we look even at one articulation between one vertebra and another, people are always focused on the disc, slip disc or degenerative disc. But between one segment, one vertebra, there are, if you look how many different articulations between one vertebra and another vertebra, there's the disc, that's with the vertebra above it. And then in between, in the back part, it's called the facet joints. So with one vertebra, there are 3 different articulations above it and 3 different articulations below it. So in one vertebral segment, there's almost 6 different articulations. So you can see how, when we're looking at the spine, it's a very complex issue just to begin with. So how do we treat spinal disorders? There are minimally invasive procedures where we can make very small incisions, very small openings, and spare all the muscle tissues to correct certain disorders, whether it's a disc herniation or spinal stenosis, which is a narrowing of the canal, which a lot of us suffer from as we age. Spinal stenosis is a narrowing of the canal, and the symptoms of that are pain in our legs when we walk. And in the area that we live in here with our population, we treat a lot of patients with that particular type of problem. There's variable ways to treat it. Some of us will just open up the canal, called a laminectomy. An ectomy is a Latin term, and anytime you remove something, it's ectomy. So a lot of times that's treated with a laminectomy. A lot of times it's treated with a laminectomy and then what we call a fusion. And there are different ways to do a fusion. A fusion, if you look at this model, is when screws are placed in the spine and a spacer is usually placed between the 2 vertebrae, and it becomes one unit. That's a fusion. This has been the standard of a lot of spinal surgery for years. The drawbacks of doing these fusions are, number one, they're kind of carpenter specific. Different carpenters or different neurosurgeons do them different ways. Some are good, some are bad, some are better than others, and some have better indications. There are procedures that we do where we can actually do a small opening and a decompression and put in a small clamp to stabilize the spine, because every time we decompress the spine for these like spinal stenosis conditions, we can potentially destabilize it. This allows the area to be restabilized and not fuse it so it still moves. Why is this more advantage than maybe doing a procedure like this called a fusion? Because when we fuse the spine, the biomechanical aspects of that issue is that when a spine moves, the spine, as we discussed, all these different vertebral segments, 6 articulations between one vertebra. As soon as you fuse one vertebra together and you're moving just a few degrees, now this isn't somebody bending all the way down, this is just a model doing this. You can imagine what happens as soon as we fuse one segment together, just one, just a few degrees of motion, the amount of energy required and the amount of breakdown that occurs at these adjacent levels because of one fusion becomes dramatic. The amount of work the next vertebra does. So we can avoid these issues through some of the newer technologies and techniques. This is a game changer for us. So these are some of the things that we look into trying to do.
You know, we have very large groups that view the show over the years. And I'd like to break it down into 2 areas, and maybe you could offer some information back to the people who I'm talking about. Of course, we have, as you nearly mentioned, really percentage-wise, we have the largest number, percentage-wise, the largest number of people over the age of 70 of any state in the union. Yeah. We have the greatest number of people over the age of 80 of any state in the union. That group the questions come from them all the time about, it's difficult for me to sit, I get a lot of pain, et cetera, et cetera. Now, I always communicate to the viewers, please, when you take care of yourself, you're taking care of your body. And instead of just going into a supermarket, a pharmacy, or otherwise, and picking something off the shelf to believe you're going to mitigate that problem, that's not really the best way. The best way is to communicate with your physician.
Absolutely. So first of all, I am a neurosurgeon. I specialize in complex neurosurgery. But as you know, I am an osteopath. And before I was an osteopath, I was a chiropractor. And my bachelor's degree is in nutrition. And I tell everybody the same thing. You can avoid an operation, avoid it. Weight loss, good exercise, physical therapy, osteopathic physician who does manual medicine. I work with these guys all the time. So if you can avoid surgery, you should always avoid it. So if it gets to the point, though, where the conservative management fails, then there are good surgical options. And I don't have an age limitation on who I operate on. I've operated on people over 100, and I've done very well. I operate people routinely in their 80s and 90s now all the time to give them a better quality of life. It's not the number, it's the overall health of the patient. And there are some techniques, like I illustrated, like this small operation. I do these on patients in their 80s and 90s. They go home the same day, 1-inch incision, and they do great. It really just depends on the issue that we're trying to target. And in that particular age population, the more common problem that we see is spinal stenosis, where the canal becomes narrow. The symptoms of that problem, where the patient says, doc, I can ride my bike all day, but I can't walk down the block. I walk, I get this heavy sensation in my legs. I have to sit down. Even at the supermarket, I sit down for 5-10 minutes and I can walk again. These are the type of symptoms. Also, they'll complain of numbness. Or, I can walk as long as I'm leaning forward and holding onto the shopping cart. It's when I stand up straight. And the reason that occurs in this population of patients is because when we're leaning forward, like holding onto the shopping cart, what happens is that the ligaments over time, they overgrow and they hypertrophy and they thicken. And as the disc spaces shrink, they become thicker. And when they lean forward, they're putting them back on stretch. So when they put them back on stretch, the thickness thins down. So when they're leaning forward, they're taking the compression off the nerves. They can walk further. So those are the kind of conditions that, we're seeing in our practice here, and we're able to help these patients with considerably. And again, if the injections help, if physical therapy helps, if back support helps, then that's the best thing to do. But when those treatments fail, we can help. And because of our holistic background, I look at all those things for our patients. I say, will a brace help? I'll give them a brace. Will a pair of foot orthotics work? Will a diet be the answer? And I wrote a book on diet because I used to be morbidly obese and suffered from the same complaints that my patients have. And I'll guide them. I'll say, look, this is what you need to do. This will help you. And if those are the modalities that help, then that's the best thing for them.
One other thing that comes up with the aged is the issue of, I think you said there was some compression relative to evacuation and urination, things of that nature. There seems to be that we get a lot of questions about that. Is that something that is very common to the elderly?
So it depends on the cause. So bladder and bowel function, you are correct, is controlled by the nervous system. So the nervous system, the spinal cord itself, actually ends before the beginning of the lumbar spine. It ends at the top, that we call L1. You have to hope you don't hear that noise. They're doing some construction. I hear a jackhammer. So the nerves end in what they call the cauda equina, which is Latin for horse's tail. As those nerves traverse in the spinal canal, if there's severe compression, it'll cause a problem with those nerves that control our bladder and bowel. Usually, those type of symptoms in the elderly don't tend to come and go when it's the nervous system. As the nerves that are traversing through the spinal canal, if they are compressed severely, it can cause an issue with bladder and bowel function, for sure. But usually those issues aren't transient. They don't come and go, they come and they stay. We call that a cauda equina syndrome because the cauda equina is the nerves that come down here. And people who have severe compression of the cauda equina, it's usually a medical emergency. We'll take them to surgery immediately so that we can take the compression off of those nerves so they can regain that function. In the elderly population, especially after childbirth and women, they can have bladder weakness, they can have pelvic floor weakness, and a lot of that can be influenced on that as well. But during the neurological exam, we're able to check for reflexes. Sometimes we'll actually, in certain patient populations where it's concerned, we'll do a rectal exam to see if the nerves that are controlling those areas are functioning properly. And we can look at all of that during our neurological examination. And when a patient's seen, we check their reflexes, we check their muscle strength, we have them walk, we check their balance, we do a complete neurological assessment to see what other issues, whether it's from the spine or some other issue that may be causing their dysfunction. We don't just focus on the spine, we really focus on the whole patient.
Okay, now let's, the other group is really split into sort of a subgroups. You have the teenagers up to about age 30, 35, and then you have 35 up to 65 or 60. We hear a lot about problems, especially now that people have, well, here we are talking to one another and we're talking by Zoom. But there are a lot of people that are now applying their work skills at home in front of a computer, sitting. We hear a lot about arm problems, my back hurts, my legs feel like they're numb when I get up. I don't know what to, it's your area, so it might be an oversimplistic thing, but I think you've already adjudicated most of the answers and presented them relative to your initial presentation. But we get a lot of requests as to what should I do?
So number one, you see the chair I'm sitting on? When they were ordering chairs, they sent me some chairs, and first thing I asked for is an ergonomic chair. I asked for an ergonomic workstation so that I'm not looking down all day. When I'm on my computer, I'm looking straight ahead. You're correct. Simple things, resting your elbow on a table all day, a ulnar nerve, when we do ulnar neuropathy. Believe it or not, just resting your hand all day long on a surface can irritate the ulnar nerve. Using a mouse or computer all day, you want to make sure that's ergonomic because you can get carpal tunnel syndrome, which is the median nerve being compressed in our hand. So simple things like that, using ergonomic chairs, making sure myself, I make sure that I wear good shoes, good sneakers, even in my dress shoes that are ergonomic, that absorb the energy of an impact every time I stand, and that I'm getting good lumbar support when I sit. Or having a workstation where you go from sitting to standing. When a person sits, it's 150 pounds per square inch at each one of these disc levels. When a person stands up, it's down to 100 pounds per square inch. So standing intermittently is much better on your back than sitting all day long because it divides the energy through both sides of your lower extremity. So simple little things like that are definitely a good thing to do. Getting on the floor, stretching, doing some yoga, gentle exercise. I make myself exercise all the time. I think, the old saying, an ounce of prevention is worth a pound of cure. It's true. And I think having an ergonomic workstation, using common sense when you're doing things, standing up intermittently, especially in the era of whether you're working from home or from an office, is important.
And then the last sort of group sort of transcends, goes beyond the teenagers, but it goes up to what I would call the people that want to be healthy. They get out and they play their tennis and they do golf and maybe even shoot a basketball every once in a while or swim and whatever. But we hear a lot about, I got back pain. I mean, I don't know what back pain means other than that's what we hear. So again, that's the last group, the subdivision of that group. What do we tell them?
So everybody can have back pain. I mean, intermittent back pain. I mean, more money is spent on back pain every year in the healthcare profession than any other illness. It's billions of dollars. And again, I think there are simple concepts in terms of, understanding that if you're going to do vigorous activities, that you warm up, that if you're going to, I have my patients get back supports when they're doing different exercises because the more twisting and bending they do, the more they're going to irritate those joints. And then in terms of surgical interventions, in the younger group that you talked about, those patients we operate on as well, because a lot of those patients develop very complex deformities and scoliosis, and we will treat those through surgical interventions where we're putting screws and rods to straighten the spine and stabilize it so that they don't have long-term issues. And in younger individuals that require surgical interventions, there are other techniques that we employ, and I had my assistant bring this other model. So in the younger age group, like you've heard, Tiger Woods had issues with his back. He was a golfer. He had a microdiscectomy. Then he went on to rub what we call bone on bone. And instead of doing a procedure that we talked about before, where, this model where a person undergoes a fusion, a spacer's been placed between the vertebra and screws have been placed because their disc wore out and they had chronic pain from the bone on bone rubbing that failed conservative management. This is a fusion. And as we talked about before, doing a fusion, what we expect would happen is that the next level will break down prematurely, because especially in the lower back and in males and in women, the first disc wears out first because that's the load bearer. So, and this is what we would do. And it'd be like an annuity. You do a fusion, and 3 to 5 years later, you're doing another fusion. The next level breaks down. So that's evolved to some of these newer technologies. And that's this model here that we actually do here at University Hospital, where instead of doing a fusion, what if we can actually take out the disc and put in a mechanical disc that mimics motion? And that's what this model allows us. Instead of doing a fusion, we can remove the disc. We can put a mechanical disc in place to allow the body to have its normal range of motion and not cause the next level to break down prematurely. So these are some of the advantages of the technology that's evolved today in terms of the surgical strategy. And of course, like we talked about, wearing a back support, keeping your weight down, Those are the things that can minimize these problems from happening.
Well, that's really the goal of listening to our viewers. I mean, the whole issue really relates to what can I do? You know, I mean, they watch us, and I guess if we've been going on now for 23 years, we must be giving them some, I hope, quality answers because we have quality people like yourself, masterful people like Dr. Stephen Vanni, who is multifaceted educational background, that's for sure. And really, it's a pleasure listening to you because you hit on every single area of requests of information. And I really appreciate it. Let me just go to one other area, and you touched on it a bit because I do believe you said that you had some interest. The issue, we live in a warm climate generally, and most often, sometimes very wet, but you know, that the bottom line is that we have to take fluids. We have to have nutritional intelligence. It's very difficult because how do you ever read the back of these items that are sitting in supermarkets or otherwise? I mean, you read it if you can. I mean, I don't know. I have to put my reading glasses on. But how do you really know what these various, I guess you could say, chemical names are or general research names rather than knowing what they really are? I mean, sugars go well beyond the word sugar, for example. What's your thoughts about that?
So, I don't want to self-promote myself, but these are things that are near to my heart. And I mentioned before, I did write a book, and I don't want to say the whole title, so I don't want to offend anybody. But my book was on common sense weight loss, and the title of my book is called "It's All BS" and bull. And I won't say the rest of the world, I don't want to offend anybody. But the reason I called it that is because a lot of the stuff that we read on labels and people are trying to get healthy, you see all these ads, take this, it'll make your brain healthier. Take this, it'll make your joints healthier. Hyaluronic acid, chondroitin sulfate. And one of my chapters in my book was called, and I'm not trying to tell people to buy it, but it's just to educate people that are listening. It's based on what we call a half-truth. And most people don't say, well, Dr. Vanni, what's a half-truth? And I said that half-truth is that they take a statement. They say they will take a vitamin supplement, whether it's vitamin D, whether it's hyaluronic acid, chondroitin sulfate, and they'll say, hyaluronic acid is an essential nutrient of our joints. Chondroitin sulfate is the building block of your joints. And it's absolutely true, 100%. But taking that pill and swallowing it and think it's going to make your joint grow back and lubricate it is total BS. No real scientific studies have been shown to do it. It doesn't work. And getting back to the point where you say staying hydrated, yes. And what I tell people to do in terms of at least weight loss, not complete overall health, you should eat smart, without a doubt. If it doesn't grow, if it doesn't fly, it doesn't swim, try to stay away from it. It's a very simple concept. Eat apples like an apple, not apple juice. Eat oranges like an orange, not orange juice. And I tell people every day that I meet and that I tell them to lose weight, it's a very simple concept that I tell them. The first thing I do is I point to my own skin or fat, and I say, do you know what this is? And it's fat is energy. This is my concept, and this is what I promote to people. And I don't care what diet you try to do, what kick it is that month, is that we weigh what we weigh for one simple reason: how many calories we eat. I don't care what anybody tells you. If it's a fat, if it's a protein or a carbohydrate, it doesn't matter. It only matters one thing: is a calorie. And I'm a car guy, and so I talk about. I like to restore cars and stuff like that, but it's simple for me. I tell everybody a couple things. All of our joints, whether it's our knees, our discs, our cartilage in our neck, They're like car tires. God gave us a certain amount of tread, and then only one thing is going to happen as we age. It's going to wear out. And if you're a Ferrari and your tires wear out, you're not pulling out of the garage. So use your tread smart. What do we mean? Don't continue to do exercises as you're getting older that are going to break down the cartilage and ruin it. Be smart. You don't drive on the racetrack. You take it out for a spin. You use your mileage wisely on your tires. You keep the weight down of the vehicle or the person. And getting back to energy, nothing burns more energy. This is what people have to understand. In 24 hours and staying alive. If you live from today to tomorrow, you're going to burn more energy than anybody my age or your age is going to burn running. If you run a mile, you're only going to burn 100 calories. And if you relied on exercise your entire life to maintain your weight, so if you ran a mile a day, you burn an extra 100 calories, that's 500 calories a week. But if you only needed 1,800 calories a day to stay alive and you're eating 2,500 or 2,300, at the end of that week and you're not running anymore, you're going to start gaining a pound a week. Because every extra 3,500 calories in a week that you consume, and it doesn't matter if it's carb or fat or protein, the body doesn't work that way. A calorie is a calorie is a calorie. It's a unit of energy. If you put in more energy than you need, you store it as fat. You put in less energy than you need, whether it's a carb, a fat, or a protein, your body's going to go to the universal store it has and remove it. That's what happens. So I tell everybody, you look up your BMR, your height, your weight, your age, they're all over the computer on your phones, and it tells you how many calories a day you need to stay alive. That's it. If you eat 500 calories less than that, every week you must lose a pound. It's science. It must happen. If you eat 250 calories less than that, you must lose a half a pound a week. That's what's going to happen. Anything else is not true. And people will say, oh, if I did that, I slowed down my metabolism. It's a complete fallacy. It's not true. What happens is when I was 300 pounds, I needed 2,800 calories a day to stay 300 pounds.
I don't mean to interrupt you, but my executive director says we're running out of time. We're proud to represent your capabilities to our people and our patients. So just know that we're very, very happy that you're within hi there distance. How about that? Thank you, Dr. Vanni. Thank you, folks, for showing up again. This program comes to you from Nova Southeastern University. This is a show which is yours. Remember, if you have any questions, want some answers, there it is right here. My name is Fred Lippman. Until next time, see ya.